Hello, everyone, and welcome. I'm sorry that Jen won't be able to join us for Q&A until the panel. So we're going to start a little bit early with Professor Arthur Wilde, who is coming to us from Amsterdam University Medical Center, where he is a professor there in Amsterdam. So he is coming across the pond to join us for his presentation. So Arthur, I'll have you turn on your camera and unmute yourself, and then you can share your screen. I see you there. Very good.
Thank you, Marcia. So let me start sharing my screen. Close the door. Okay. Thank you for the invitation to be present at this SADS annual conference. I actually had preferred to be present in person, but that's still not that easy, and I hope it will be possible in the near future. So you asked me to speak about universal screening for SADS conditions, and the subtitle then is which ones, when, and how. And you already introduced me. I'm Arthur Wilde. I'm working in the Academic Medical Center in Amsterdam, the Netherlands. So which ones, when, and how, I will go through each of them. But first define which conditions I will discuss. I think SADS is obviously the abbreviation stands for sudden arrhythmic death syndrome. And that implies that all the electrical heart diseases are involved here. And I will elaborate on the next slide. But also some of the cardiomyopathies may be involved, but only when it is preclinical, meaning that, for example, a hypertrophic cardiomyopathy patient may have severe arrhythmia while not having hypertrophic cardiomyopathy yet. And I think part of that is covered by SADS as well. So the electrical heart disease, the primary arrhythmia syndromes, are the long QT syndrome, the short QT syndrome, Brugada syndrome, and some of you may suffer from either condition, or catecholamine-induced polymorphic VT, and then there are another couple of them which are more rare, short coupleters at the point, idiopathic ventricular fibrillation, and isolated conduction disorders. They are not that relevant for the talk today. So why would you screen for arrhythmia syndromes in the population? That is obviously to prevent sudden death, which is a common feature of all these diseases. And the way to do it, so how would you screen for these arrhythmia syndromes, is with an EKG, and that is a normal baseline EKG, the regular EKG that you have every time you visit your cardiologist. That is a 12-lead EKG. And with that, you can find evidence for either long QT syndrome, short QT syndrome, Brugada syndrome, or isolated conduction disorders. And the other ones are not picked up by a regular EKG. If you add to the screening an exercise EKG, which is quite cumbersome, of course, because that is really something that takes time, and then you will also be able to find evidence for catecholamine-induced polymorphic VT when that is present. You really need an exercise EKG for this one. All the other ones in red here may be picked up by a regular EKG. So I will discuss the case of the long QT syndrome and view it from two sides. I will discuss a paper which has been published over 10 years ago by the group of Peter Schwartz, who is an advisor of the SADS US as well. And that he shows clear evidence that you may pick up patients with long QT syndrome. And the subtitle here is the yield of population screening for long QT syndrome. At the other hand, I will also discuss a paper from Sami Viskin, which clearly shows how difficult it actually is to measure the QTC. And that is important if you want to define who has long QT syndrome or who has not. You need to be able to measure the QTC accurately. So the first paper to discuss is this paper of Dr. Peter Schwartz and his group, published in Circulation in 2009. And this is about the prevalence of the congenital long-QT syndrome. And what they did, they made an EKG in almost 45,000 children at the age of 15 to 25 days, so that is shortly after birth, in 18 North Italian hospitals. And when the QTC was over 450, they advised a repeated EKG, and when it was over 470, they referred for genetic testing. Normal values for the QTC are 440 or 450 at this age. I don't think it matters a lot whether it's a male or a female. At adult age, the normal values for males are 440 and for females are 450. And this is their result. So almost 45,000 children, babies screened, and the vast majority, almost 42,000, had a completely normal EKG. 900 had an EKG that is over 440. Only 177 had an EKG over 450. 28 of them had an EKG over 460, and 31 of them had an EKG over 470. And in the group that has these longest QTC interval, they did genetic testing. In this, only in 12 of 28 individuals with QTC over 470. So that's 43%. They did genetic testing and found a variant in one of the long QT genes. So almost proving, I think, that these patients suffer from long QT syndrome. And in the patient group with a slightly less prolonged QTC, they did genetic testing in 4 out of 40. And also, so in these individuals, they found also long QT mutations. So altogether, in 16 patients, there was genetic evidence for long QT syndrome, but the EKG having evidence for long QT syndrome was in the 28 plus the 31. Then the paper of Sami Viskin, published a few years earlier, and that is to show how difficult it actually is to measure a QTC interval. And what he did, he had 4 EKGs, and he sent that to 902 physicians. 25 of them were long QT experts. Dr. Ackerman and I were part of that. 106 were arrhythmia specialists, so cardiologists with a daily life in cardiac arrhythmias. 329 were cardiologists, not specifically specialized in arrhythmias, but general cardiologists, and 442 were non-cardiologists. And the 4 EKGs he selected were these 4 EKGs, and the top 2, panel A and panel B, were from a long QT patient, and the bottom 2, C and D, were from patients without long QT syndrome. And the question was a simple one to all these 900 plus cardiologists: can you please measure the QTC of these 4 EKGs and give us that particular value? And this is what was then subsequently found. So in red, you see the judgment of the QT experts. In green, you see the judgment of the arrhythmia experts. In blue, of the cardiologist, general cardiologist. And this purple color is a non-cardiologist. And this is a panel. This is from a long QT patient. This is from a long QT patient. And this is trace 3 and trace 4 are for patients with a normal EKG and who didn't have long QT syndrome. And what is important here to recognize is that if you focus on the red to start with, and in this panel 2, trace 2, trace 3, and trace 4, you can see that there is a very narrow band in assignment of the QTC interval, which means that the QT experts agree on the QTC value. It is just below 500 in trace 2. It is around 0.4, which is 400 milliseconds in trace 4, and similar in trace 3. So the QT experts had agreement on the QTC interval. And this one, it's a little less, it's still centered around 500. 0.5 is 500 milliseconds. But it is at least a consensus, but the other 3 are pretty good consensus. The arrhythmia experts had already a wider range of QTC assignment, which means that the individuals do not completely agree. That is not the case here, because here the width of the curve is similar, but here it's clear that, some of the arrhythmia experts consider the patient to have QTC of 420 and others of 550. What is more concern is that the cardiologist and the non-cardiologists have a complete disagreement on what the actual QTC on that particular trace is, and that holds for all 4 traces. In the patients with long QT syndrome, it's a complete mess, as you can see here, and in the traces with patients with normal QTC, there's also still a very wide band varying between 300 milliseconds to almost 600 milliseconds here and also here. So that means that it's very difficult to measure a QTC interval. So the conclusion from that paper, I think, is a simple one. Measuring the QTC is not so easy. If you measure it too long, you should realize that then the patient becomes a false positive long QT patient. He has a QTC that is measured too long, and a cardiologist may think the patient has a long QT syndrome, but that is actually not the case. You can also measure it too short, and then the patient has this false negative. So the QTC is not measured correctly, it's measured too short. The patient does have long QT syndrome, but the cardiologist who measured that QTC doesn't consider it like that. On the other hand, it is also to be concluded that if there is a very long QT, that is from the paper of Dr. Schwartz, it might probably be picked up, but that is at the expense of many individuals with only minor QTC prolongation. And we should realize that that paper of Dr. Schwartz is a study. That means that all the EKGs have been concluded read by QT experts, and they are those who can really do this properly. But if you would have done the same study with cardiologists or non-cardiologists, the results wouldn't have been that nice. So if we then focus on the when and how, that is a different issue. If we think about the population level, you can do it after birth, immediately after birth. These are inherited conditions, so most of them are visible after birth. You can do it in school children, which is another point in time that you can make this EKG, or you can do it at older age. And these examples are not taken accidentally. This is because in Italy, it is actually done in the 2 weeks interval after birth, as in the study of Peter Schwartz that I just showed you. And in Japan, there is a very active program making EKGs in school children. I think even at 2 times when they are just at the primary school and when they're somewhere at high school, the Japanese government demands an EKG of every child. And I'm not aware of any population program at older age. You can also do it in specific populations, and that is still under the umbrella of population screening. And for examples in athletes, which then is referred to as pre-participation screening. So before you start an athletic career or before you enter a specific sports or specific team, you will have a cardiological screening. And the athletes, I'm referring to the athletes here, and I'm going to elaborate a little bit on that, is because that is a population that has been studied in detail over the past many years. So in Italy, if you are dealing with athletes, every individual who wants to participate in sports will undergo an investigation where there is an extensive history taking, including the family history. And when the athlete is at the professional level, it will include an EKG and it will include an echo. In the rest of Europe, this will only be history taking, family history taking, and an EKG. And in the US, as you will see in a minute, it actually is mostly related to only history taking. This is the next. This is a table summarizing the International Sporting Federation with their pre-participation cardiovascular screening policy. And this only is for athletes and professional athletes, elite athletes and professional athletes. So this is the top of the group of athletes. And if you don't do it here, I think you can safely conclude that you don't do it at athletes who perform at the lower level. Now, if you focus here on the US national associations, there are 4 in this table. And if you look here, here's physical examination, here's personal symptom and family history. This is a 12-lead EKG, and this is the echocardiogram. And from this table, it becomes clear this table was from a few years ago, so I assume it's still the same, but Dr. Ackerman may elaborate on that maybe in a discussion later. Only the NBA recommends a physical examination of personal symptoms, of family history, and an EKG. And the other US organizations like the National Football League, the Major League Baseball, and the National Hockey League, they do not perform an EKG, neither do they perform an echocardiogram. And several of the European associations, as you can see, there is a 12-lead involved or an echocardiogram, but that mainly relates to the Italian sports physicians, as I mentioned a minute ago. This is a study published after the Olympic Games in 2016 in Rio de Janeiro in Brazil. And this is a table that we won't go into detail, but this relates to athletes that have been performing at the Olympic Games in Rio. And 86% of these athletes were screened more than once, or more than once. 70% had annual screenings, 75% had an EKG performed. So that also means 25% of these top elite athletes never had an EKG performed. Only 32% had an echocardiogram, and only 30% had a stress test. And the national differences across the world are here in this nice figure. So all athletes having all these investigations performed is in a few countries, Canada, a couple of European countries, Russia, China, Indonesia, here South Africa, Argentina. Most athletes are in the US and in Australia, and there are many countries around the world where only some athletes or few athletes or no athletes at all are screened. So I mentioned already that the reason to do this relates to the rare occasion of sudden cardiac deaths for these athletes when they are involved in competitive sports. And this is a paper from a Canadian group published in the New England Journal of Medicine 2017, where they found an incidence of sudden death in athletes in competitive sports of 0.76 per 100,000 athletes per year. So that means that if you have 100,000 athletes performing in competitive sports in 1 year, that 0.76 or less than 1 will suffer sudden death event. In the general population, that is regarded higher, up to 5 per 100,000 persons per year. And with all the investigations done, the conclusion of this paper was that 80% was not detected with screening with consultation and EKG. So limiting your pre-participation screening to a consultation, that is family history and history taking, and an EKG, does not lead to detection of the vast majority of individuals who later will suffer from sudden death. This is a good example and a very recent example. I'm from Europe, so we all watched the European Soccer League games in June this year. And this was a player from Denmark, Christian Eriksen, number 10. And he suffered a cardiac arrest during a game against one of the competitors. And this was it was against Finland. And this was live on television when all this happened. And the players from Denmark all went around him. He was resuscitated and he survived and he is fine now. But you can be assured that this player has been investigated on a yearly basis with everything you can do. He had an echo, he had an exercise test yearly, he had an EKG yearly, history taken yearly. And nevertheless, he suffered this serious event during this soccer game. This is a paper from Belgian colleagues where they present data on the harms and the benefits of screening of young people to prevent sudden death. So this is what happens with all these screening. And first of all, the general pre-participation screening leads to 30% of referrals. So 30% of athletes are referred ultimately to a cardiologist. And that leads to anxiety, to psychological harm, to unnecessary and unwarranted restrictions and disqualification from sports. It also can lead, that's not unimportant, to impediments to insurability or employment opportunities. And also here, 25% non-detection rate was found. Now, where does all this fear actually comes from, or the idea that all this pre-participation screening may actually prevent sudden death? And that is from this single paper published in JAMA in 2005, 2006 by a group from northern Italy, Domenico Corrado. He's a well-known colleague in this field and actually a very kind person. And he published trends in sudden cardiovascular death, young competitive athletes before and after implementation of pre-participation screening in Italy. And this is the main figure of that paper, and this figure is always the first figure to be shown by colleagues who think that pre-participation screening is useful. And what they show here is that there is a sudden death per 100,000 persons per year in the screened athletes. And you can see it is around 3.5 per 100,000 individuals per year in this range for about 3 years. And then the Italian government started pre-participation screening. And then it dropped to 0.51 per year. Per 100,000 persons per year. And in the unscreened non-athletes, the level is in this range over all these time periods. So from this study and from these data, the authors concluded that pre-participation screening is very effective in reducing the number of sudden deaths during sports or in athletes. Because prior to participation screening, this was the level, and after pre-participation screening, the level dropped significantly. Now, what happened in the years thereafter is that many other countries tried to get the same results. And this is from a paper published not so long ago where they summarized the different data. This green curve is the one that you have just seen. This curve over here is in this panel, this green curve. So 3 years with a pretty high incidence and then much lower after the start of the screening. The same thing happened in Israel. But as you can already see, there is marked variation across the years over time. And in other countries, in Minnesota, which is where Dr. Ackerman resides, it doesn't make a difference whatsoever. The prevalence of a sudden death case is very similar, and the same holds for France. So we now believe, and many of us believe, that the Veneto data, Veneto is in the northern part of Italy, are actually due to natural variation, not due to the to what the Italians started to do in terms of pre-participation screening. And that is also because the effect of the screening was not replicated elsewhere in the world. So if population screening, and I took as an example the pre-participation screening in athletes, which can be regarded as a kind of population screening, is not an option, what then is the alternative? And I believe, and I strongly believe, that the alternative is a very targeted active screening policy. First of all, in burdened families, that's where the SADS Foundation plays a very important role. If there is a family where something happened or where a diagnosis has been made, other family members have to be motivated to go to a cardiologist and go for the active screening. Also, hospitals or cardiogenetic groups can take the initiative and approach the family members actively. So that is targeted active screening in burdened families. And the same, obviously, should be done in individuals with relevant complaints. I'll show you an example how we do it in the Netherlands. And I realize the Netherlands is a small country compared to the United States. And what we have done here might not be feasible in the United States. But still, it is a good example what you can reach with active screening. This is published in 2007, so 13 years ago now. And at that time, the screening for the long QT syndrome was only done, the genetic screening was only done in Maastricht, which is a city in the south here, in Amsterdam. And in these data, we have included all referred probants to molecular diagnostic labs in the period of 1995 and 2005. Altogether, that was 421 individuals. We grouped these individuals to their postal code, and the postal code here starts with either 10, 11, 12, and goes up to 99. And the figures that you will see in a minute is that are indexed per 1 million persons. The prevalence of the long QT syndrome is 1 in 5,000 or 1 in 2,000. That means that we do believe that 1 in 2,000 individuals has a long QT syndrome, and that is important for what comes later. And if you find a proband with long QT syndrome, the mean number of family members that we have identified is 4.5. So we multiplied every proband that we screened with 4.5 to see how many individuals we have already identified. Now, this is the map of the Netherlands, and the color code, these are all the different postal codes. And the darker the color in a given postal code, the more individuals with long QT syndrome in that particular area have been identified. So you see that there are areas where there are many long QT syndrome patients identified, but you also see that there are areas where there are virtually no patients with long QT identified. There are 3 areas where that stand out with a lot of long QT patients. This area, and this area. And the interesting point is that these areas are around the university with interest in the long QT syndrome. So here's Amsterdam, and we have a clear interest in long QT syndrome for many years. And apparently our program is not doing so bad because we identify the patients in our region. The same holds for the south, whereas there is Maastricht. That is also a center with long-standing interest in long QT syndrome. And also here in the north in Groningen, there is a long-standing interest in long QT syndrome. And I don't think that is by accident. That is that we actively and are in contact with our primary physicians. So there is interest in the long QT syndrome, and it means that patients with a long QT syndrome are easily identified. It's also to be concluded from a graph like this that there is a large difference. The minimum of patients identified in a specific area are 3 per million, and the maximum is 110 per 1 million. Now, if you have this map, the reverse of this map is the number of patients that has to be identified. That is simply based on the number of patients that live in this particular postal code. And then you subtract the number of patients that have already been identified. And if you take, as an example, 1 in 2,000 patients, 1 in 2,000 individuals should have long QT syndrome, you can make an estimate of the number that still needs to be identified. And then you can see that there are still there's certain areas in the country where there's virtually no patient identified and where there are many supposed to be. And that means that you can actually target your education on the low QT syndrome to these regions where no patients have been identified. So we actively approach the cardiologist in this region and the primary physician in this region to give them education about the long QT syndrome in this case, but other inherited arrhythmia syndromes, you can of course do the same. And that is all in the hope that the local physicians will be aware of what these diseases actually are, so that they more easily identify their patients. So a very similar proactive screening should be done in burdened families, as I mentioned. That is to promote active screening. That is what is done in centers like the Mayo Clinic, and there are several centers around the United States. But you should do it very actively, proactively. That means refer all family members to the doctors who know what these diseases are. And it's also important to raise awareness on alarm symptoms. That's actually what SADS does in the October month, for example. And the same holds for individuals with symptoms. You have to promote active screening. You have to do the appropriate investigations and raise awareness on the alarm symptoms. And that brings me to the end of this presentation. Thank you very much. I'm very much willing to address questions. I suppose that will be done in the question and answer session that follows now. Thank you very much.
Thank you very much, Dr. Wilde. We have a couple questions that folks have posted. So I have 3 questions for you that are in our posted in our Whova app. 1 second here, let me get to those. Okay. How can there be universal screening early on?
Yeah, so early on, I suppose what the person who asked this question is universal screening early on is early age, maybe.
Yes.
That is what they do in Italy. I showed you the example of what they do in Italy, but this was in the study protocol. I think the main problem with that policy is, and that's why I showed the second paper of Dr. Viskin, if you do it on the population level, you cannot rely on the few QT experts that are around because there are too many EKGs to be judged. So you have to rely on cardiologists, maybe even on non-cardiologists, given the number of EKGs to be screened. And I've shown you how difficult it actually is. So I don't think that will lead to a reliable result. So I'm convinced that that is not the way to go. I showed the example of the Netherlands with the long QT syndrome. At the time, I didn't give that number, but in 2007, based on what I have shown, we estimated that at that time we had identified about 40% of patients with long QT syndrome in the Netherlands in 2007. And by now that number should have been doubled. So I believe, and I'm pretty convinced that by now we have identified 80% of individuals with long QT syndrome in my country. That doesn't mean that there may not be new patients, but every population screening program has so many disadvantages, as I hope I have convinced you, that it's not worthwhile to look for these very few. At the other hand, we have identified the vast majority of long QT patients already, and they are all on proper treatment.
Okay, thank you. Do you think that some of the cases of SIDS are related to SADS conditions? And I wonder if sometime in the near future, if states can add SADS testing to infant or newborn screening, would that be ideal?
Yeah, so I do believe indeed that some of the, and I think that pretty sound data on that, Dr. Ackerman's group contribute to that, that part of the SIDS relates to SADS conditions, long QT syndrome in particular, CPVT maybe. The estimate is that will not be more than 20%. So 20% of SIDS may relate to the SADS conditions. And screening for that, that is the same question as I just addressed. That would mean an EKG in everyone. And that leads to the big problem that who is going to judge these EKGs, who is able to recognize the SADS conditions that need to be taken care of. And whenever you start a program like that, you have to realize that you, in 1,000 patients, as are the data from Dr. Schwartz showing, in 1,000 patients that are identified with a prolonged QT, only 30 have real long QT, and the other 970 don't have the condition. And you will raise anxiety in all these families and all these families in particular, that there is something wrong and that might lead to SIDS, and then what next?
Okay, thank you. Here's a comment and a question. In New Jersey, US, at every wellness visit, pediatricians now ask a series of 5 questions to determine if a heart issue may be present. This allows them to send children for further testing. This seems like such a simple approach. Why isn't this done nationally?
Yeah, I don't think that I can answer that question because I'm of course not involved in the US situation, but I think that's a very reasonable approach and a very practical approach. Simple 5 questions. That's what you do with athletes. I'm pretty sure within the 5 questions there will be one related to the family, as ever something happened in your family will be one of these 5, I suppose. And that is a very practical way of identifying the families where really something is wrong. So I would be very much in favor of a system like that.
Very good. Are there any considerations to include SADS conditions in newborn screening? Maybe where you are or others places?
Yeah, we haven't done that yet. In the newborn screening, that means genetic screening. That means that you put these long QT genes, for example, in the newborn screening panel. And the big problem will be that you will find variants in these genes, and you don't know whether it means something. That is a very serious problem. And with genetic screening, every individual, every family has its private mutations. And you will find, for example, in one of these genes, the yield of variants that doesn't mean anything. It's between 3 to 8%. So you will find variants in 3 to 8% of the screened babies, and that doesn't mean anything. And the rare variant that does mean something, you will pick that up as well. But it is at the expense of so many that doesn't mean anything. So that's a dangerous approach.
Okay, let me see if there's any more questions here. Posted. So this is kind of related to some of the earlier questions. It makes me sad when I hear news about someone dying suddenly, and always wonder if it's a SADS condition. My question, can there be screening for people with a family history of heart conditions?
Yeah, that is what I meant to say under the in the slides about the burdened families. If there is a family where already somebody has died suddenly, I think that there's a very good reason to take a very active approach and screen all the immediate family members with the relevant investigation, which would include an EKG, an exercise test, and an echo. And then you will find, and the yield of that is actually pretty significant, pretty substantial. In about 20–30% of families where somebody died suddenly at an early age, you will find one of the SADS conditions, which is very relevant to start early treatment.
Exactly. So if universal screening isn't the best option, what can be done to help prevent cardiac arrest as the first symptom for those who unknowingly have a SADS condition as a VUS mutation not inherited from the family?
Yeah. So I believe that the way to go is a very active approach in these with these conditions by cardiology or by cardiogenetic departments. If there is somebody with a condition, you proactively approach the family members of that particular person. And I hope I have convinced you that, sorry, in a small country as ours, where we have been able to identify in 2007, that was only 10 years after this field started, already 40% of our long QT population. And by now we haven't repeated that investigation, but my assumption is by now this has doubled, so we might have identified all the long QT patients in our country. And I think that is the way to go, but that starts with an active approach in families where that is present. You have to convince these families that they need to refer their family members, and you can go from you of course start within the immediate core family, but then you go to one of the parents and to the family members of the parents and further on, and that may actually lead to families that become as big as 200, 300 individuals.
Okay, thank you very much, Arthur.